okay with you, I also see another scholar is on.
It's Amber Pedro from Sayre, Pennsylvania.
Hi.
Hi. I know, these are becoming my favorite series scholars, y'all.
So, everyone, welcome. Thank you all for being here. This is the Learning Curve, a geriatrics professional development series. My name is Lauren Jones, and as you all know, I'm the Geriatric Scholars Program Manager at the Grant here in Los Angeles. This is the third webinar in the three-part series. The topic today is health literacy, and our speaker will be Dr. Ronnie Chernoff. This series is sponsored by the Employee Education System, EES, in collaboration with the Consortium of New York Geriatric Education Centers, the Arkansas Geriatric Education Center, and the Geriatric Scholars Program, which is funded by the VA Office of Rural Health. The presentation will last about 40 minutes with a Q&A time until 3 p.m. Eastern Standard Time. Please type in your questions under the Q&A tab on Live Meeting, and the presenter will verbally answer it in the order in which it was received at the end of the session. And if necessary, you can raise your virtual hand by using the Q&A tab. There's a hand icon on the far right-hand side. The session will end promptly at 3 p.m. Eastern Standard Time. If you have any further questions for the presenter, please send them to me at lauren.jones@va.gov, and I'll forward them. For your convenience, you are pre-registered for this meeting. To receive CME, CEU, and to complete your registration, you must contact your Business Satellite Coordinator using the list I emailed you and request the registration evaluation form for the course. If you have any questions about the process, please refer to the email we sent you for the ES contact. I'd like to first introduce our speaker for today, Dr. Ronnie Chernoff. She's the Associate Director for Education and Evaluation for the Geriatric Research, Education, and Clinical Center, the John L. McClellan Memorial Veterans Hospital in Little Rock, Arkansas. She's the Director of the Arkansas Geriatric Education Center, Professor of Geriatrics in the College of Medicine, Professor of Health Education and Health Behavior, the College of Public Health, Director of Education in the Donald W. Reynolds Center on Aging at the University of Arkansas for Medical Science. She received her BS nutrition from Cornell University in Ithaca, New York, and an MS and MED in nutrition from Columbia University in New York, and her PhD from the University of Pennsylvania in Philadelphia. Dr. Chernoff has been the recipient of over $5 million in grants and contracts. She's also been a prolific author and editor, editing 5 books, publishing 38 abstracts, 43 journal articles, and 108 other publications, including book chapters, invited reviews, and other articles. Her books include Health Promotion and Disease Prevention in the Elderly, 3 editions of Geriatric Nutrition, a Health Professional's Handbook, with a 4th edition anticipated in 2011, and 2 editions of Communicating as Professionals. She has served on the editorial boards of 6 peer-reviewed journals. Dr. Chernoff is also involved in the Gerontological Society of America, having served on the Long-Range Planning Task Force for the Society, was the Clinical Medicine Section Research Committee Chair and the Clinical Medicine Section Chair for 2003 and 2004. Finally, she has been involved in many other professional activities at the National Institute of Aging, the Administration on Aging, DHHS Public Health Service Committees, the Surgeon General's Office, VA Healthcare Reform, Health Resource and Services Administration, Bureau of Health Professions, and the Center for Medicare and Medicaid Services, to name some. With that said, it is my pleasure to welcome Dr. Ronnie Chernoff. Dr. Chernoff?
Thank you, Lauren. I'm going to try and keep this fairly casual, considering the number of people who are online, but our topic today is health literacy in older adults. One of perhaps the greatest barriers in doing any kind of health education is making sure and assuring that your patient or client understands and comprehends what it is that you have told them. So what I wanted to do today was to go through some definitions, a brief study that I will tell you about, and then talk about how do we make messages clear enough so that our patients or clients can understand what it is that we're talking about, and be able to incorporate the advice that we give them into their daily lives. Literacy is defined as an individual's ability to read, write, and speak English. I'm having trouble with that today. And compute and solve problems at levels of proficiency necessary to function on the job and in society and in their day-to-day lives. Literacy is using printed and written information to function in society, to achieve one's goals and to develop one's own knowledge and potential. In 2003, there was a national assessment of adult literacy conducted by the National Center for Education Statistics to measure the literacy skills of American adults. A nationally representative sample of more than 19,000 adults were assessed using tools that measure literacy tasks directly. Tasks used to measure health literacy were organized around domains of health and healthcare information and services, and these were categorized as clinical, prevention, and their ability to navigate the healthcare system. The background information that was collected included general demographic data and specific health-related questions. The background information included general demographic data, specific health-related questions that addressed issues in health status or perceived health status, preventive and health practices, health insurance coverage, and sources of information about health issues. The study measured three different types of literacy, which I will explain in 10 seconds. Prose literacy, document literacy, and quantitative literacy. Prose literacy is defined as the knowledge and skills needed to search, comprehend, and use information from continuous text, such as editorials, news stories, brochures, and instructional materials. Document literacy is the knowledge and skills needed to search, comprehend, and use information from non-continuous text, such as job applications, payroll forms, transportation schedules, buses and train schedules, for example, maps, tables, and drug and food labels. Quantitative literacy is the knowledge and skills needed to identify and perform computations using numbers that are embedded in printed materials, such as balancing a checkbook, calculating a meal tip, completing an order form, and determining interest on a loan. Literacy levels were stratified as below basic, which is having the most simple and concrete skills. Basic for people who can perform simple and everyday literacy activities. Intermediate for people who can perform moderately challenging literacy activities. And proficient can perform complex and challenging literacy activities. The results were that a lot of people, in fact, are non-literate in English. 7 million adults could not answer simple test questions. 4 million adults could not do tests due to a language barrier. Okay, so if we look at prose literacy, there were 14% below who were below basic, 29% who were barely basic, 44% who were intermediate, and 13% were proficient. The conclusion of the study was that 43% of adult Americans cannot perform moderately challenging prose activities. The characteristics of those who had below basic literacy scores were those who had not graduated from high school, did not speak English at home before starting school or English as first language. They were Hispanic or Black. They were over the age of 65, and they had multiple disabilities. The healthcare providers who were the person in the home who were providing the health care for the patient or client was the lowest among adults aged 65 and older. The literacy increased with increasing levels of education. White adults had higher prose literacy scores, and employment, income, family, and community were all positively correlated with literacy. Well, what does this mean to us? It means that health literacy affects the ability of an individual to read patient education material, to read prescription labels, to read appointment cards, to read consent forms, to navigate the health care system, and to share their personal information. Literacy is the single best predictor of health status, more than age or income or employment status or educational level or racial or ethnic group. Adults age 65 and older had lower health literacy scores than any other age group. Those living below the poverty level had lower health literacy scores than adults living above the poverty level. Those who received their health insurance from their employer, military, or private company had higher health literacy than those receiving Medicare, Medicaid, or had no health insurance. Starting with high school graduation or equivalent, health literacy increased with each higher level of educational attainment. White and Asian Pacific Islanders adults had a higher health literacy than did Black, Hispanic, American Indian, and multiracial adults. Women had higher health literacy scores than did men. I would suggest that that had to do with the fact that they are the primary health care provider in their family. Adults with low literacy were more likely to get health information from radio and television than from written sources, such as a newspaper or a magazine or a book. Adults with higher literacy received their health information from newspapers, magazines, books, brochures, or the internet. Poor health literacy leads to lack of preventive care. These patients may never have had influenza or pneumococcal vaccinations, a pap smear, a mammogram, or colorectal or prostate screening. These patients may know less about chronic diseases such as hypertension, diabetes, asthma, or HIV, among others. They will know less about the risks of smoking, about post-operative care, and about contraception. Patients with low literacy have more emergency room visits, more clinic visits, and are hospitalized more. One of the reasons for this is that noncompliance with healthcare recommendations may be related to low literacy levels. Patients with low,
Wait.
Okay. Now we're going, why are we going backwards? Oh, I see. Well, low literate patients may not take their medications correctly or may miss appointments. And I think we're all familiar with the patient who, on antibiotics, who stops taking them when they feel better and doesn't complete the cycle of medication that they've been given. Okay, so let's talk about the elements of effective communication. The first element of effective communication are effective written communication. How do we deal with that? How do we as health professionals deal with that? One way is to develop easy-to-read forms or to provide access to easy-to-read forms. They should be written in a plain language, and the hardest thing to do is to write a complex set of directions that is focused on someone who has a literacy level of approximately, or reading ability of approximately third grade. We use multi-syllable words when single syllables will suffice, if that's all possible. So we want to keep it in vernacular English so that anybody can understand it. We want to provide relevant examples. I often talk about the concept of people approach the world and new information with a screen that's called "What's in it for me?" And if we can link what it is that we're trying to tell them to something that they can personally use or something that relates to their particular situation, it will become much more relevant for them and much more comprehensible. We need to be specific, and the general things sometimes get lost in translation. And if we could be as specific as possible to apply things to the individual's personal experience or their personal situation, then it will make a whole lot more sense to them. One thing that we try to use is to get feedback. So we want to get the client or the patient to give feedback through questions. And I'm going to address that again in a couple of minutes. We want to provide forms in as many languages as we can. We have, the VA in particular does do things in Spanish, depending on where in the country you are, particularly California. They may need more languages than that. And one of the things that we have here at the university is that we have certified translators, both in pre-op and in outpatient clinics, to help people who need help with interpretation because they really haven't mastered the English language for a whole variety of reasons. We also want to train staff to provide assistance and to recognize when it is that they need help. All of us being in geriatrics really pay attention to the fact that talking louder to people who don't understand the language does not make it any more comprehensible. It just makes it loud and incomprehensible. We want to limit the message to a few key points. Overwhelming non-medical people with medical information, they may pick out a few words here and there, and they will basically ignore the rest. It makes little sense to try and do too much at any one time. And as you all know, I am a dietitian, and one of the things that we try to do is change the native diet of the individual as little as we possibly can. And if several changes have to be made, we will do one change per clinic visit, because trying to change everything all at the same time becomes insurmountable. It just becomes something that most of our patients really can't deal with, understand, and they will select what it is that they do understand, or discard the whole thing. We give them forms and we give them directions, and they ball it up and throw it out before they're even out of the building because it makes no sense to them. So we want to limit the message to just one or two key points and not overwhelm them. We want to present concrete examples and give them some notion of what it is that you're talking about, and try to convey the really most important message one at a time. We want to repeat and reinforce the most important points, so what may seem easier to do may not necessarily be the first thing that you want to do. The content should be age appropriate, and with our patient population, we need to link it into the fact that the patients and clients who we have grew up in a different environment, and whatever they learned as a child or learned from their mother, who was the primary source of their health information, may not necessarily be something that we want to reinforce now, and we should be very aware of where it is that our patients or clients actually grew up and what the healthcare system, what interface with the healthcare system they have actually had before. The content should be culturally appropriate. It once again requires some getting to know the patient before we start telling them what to do. The reading level should be no higher than the 5th grade. but third for limited literacy groups. And I really and truly, I can tell you from personal experience, this is an extremely difficult thing to do, is to write it so that people really do understand what it is that you're saying to them in pretty clear, very simple terms. Sometimes it's very frustrating for us as health professionals to try and do that, but it is a necessary evil, if you will, if you want to be an effective communicator with your patients. One of the things that often helps is to add drawings to explain what you're talking about. They should be simple. You may have a template that you may want to use, but you want to avoid too much detail and complex diagrams. It really, sometimes, this is one of these cases where a picture really and truly is worth 1,000 words. You want to provide visual step-by-step diagrams or pictures, and it doesn't really matter what the topic is, but most topics that we talk to our patients about can in some way or another be illustrated so that the individual can understand what it is that we are trying to communicate to them. If we're doing written communications, use a large type font. Use at least and no less than a 12 pitch, but we can use 14 or 16 or headline in order to make it legible. We want to limit the number of fonts. The most distracting thing you can do is have different fonts all on the same form and all on the same page. Avoid all capital letters. Turns out that if you have all capital letters, that people have a more difficult time in distinguishing between the letters in a word than if you use capital letters for the beginning of the sentence or the beginning of each of the words. You may want to use headings and bullets to illustrate your point. You want to avoid using long sentences. People who have a low level of literacy will not be able to read it. A lot of our elder adults may have learning disabilities that were not ever diagnosed because when they were in school, that just simply wasn't an option or an issue. And perhaps the most important thing is to leave a lot of white space. This is sort of, I think, very interesting, and I don't know if any of you are familiar with a project that was done some years ago to train people in nutrition, but there were some focus groups that were done, and we all assumed that given the choice of colors and papers and fonts and what have you, that people would like really bright, strong colors, or the pastel colors, and that they would like the pinks and the light blues and the light greens and the pale yellows. And in fact, we were surprised to learn that they really prefer the strong contrast colors. One of the reasons for that was that it was easier to read something where there was a strong contrast between the lettering and the background. And so that's what I have done on this slide, is use a strong background color. We want to use captions to highlight information, and once again, keep it simple. So we can create effective written communication with people who have low literacy, and we can do it in different languages if that is required and needed. And we can use small, simple illustrations. We don't want to distract people with a lot of fancy graphics. They find it very, very distracting and prohibit them from being able to read what is on the paper that we have given to them. Okay, so now we've got the written communication pretty well down. What about the oral communication? Perhaps the most single important thing about oral communication is to listen. slowly. That may enhance people's comprehension of what it is that you're saying. Volume is not a consideration. Some years ago, I was involved. Some years ago, I was involved in a study where we were trying to assess counseling skills of, particularly of dietitians, and we videotaped them. And we noticed that during these consultations, that when we were looking at the tapes afterwards, that nobody bothered to listen to the client, and they just talked at them, and fairly rapidly at that, for the entire period of consultation, and nobody really understood what it was that they were being told. And worse, the person doing the counseling really didn't know what it was that her clients actually needed because she never bothered to listen to them. And in our particular instance, it really is perhaps the single most important skill that we can have. You want to sit during the meeting. Sitting is a great equalizer. And a lot of people are intimidated by having a person in a white coat stand over them. It's really an authority thing, and in order to sort of lower the anxiety level of the patient or the client, being on the same level with them during an interview or a counseling session is a very easy strategy to employ. It is important to get feedback and have the patient respond to what it is that you have said to assure yourself that they have in fact understood. It's a very good technique to use, I believe I've just said it, in the written communication, is to get them to give you feedback. You want to encourage questions. It is extremely important that, particularly with low literacy people, that they have an opportunity to ask questions. One way of encouraging this is to ask, what questions do you have? Not, do you have any questions? Asking them if they have any questions is sort of intimidating. If you assume that they're going to have some questions, you've given them a very large opening to ask you questions when you ask them, what questions do you have? So we try to use plain language and plain knowledge, that which is common. We use effective or create an opportunity for dialogue or conversation, and maybe that's one of the things that you get out of listening. We want to create what are called orienting statements, and this originally was done in nutrition, or you can use it for anything. Let's talk about your favorite food. Let's talk about what your hobbies are. Let's talk about something that puts the client at ease and shows your interest in that individual. They're much more likely to hear what it is that you're saying if they think that you're the only one, they're the only one to whom you've ever said this. So you can, it's sort of an icebreaker, if you will. Let's talk about your favorite whatever. Okay, the same thing with effective written communication. Effective oral communication is limiting the information at each meeting. Stress the most important point that you want to make with your patient or client. Your blood sugar is too high, and we need to discuss what you can do to control it. Your blood pressure is too high, and we need to discuss what it is that we can do to control it. And then re-emphasize the most important point that you have made. With effective oral communications, you can draw or use pictures to illustrate a point. You can use verbal and written explanation together. You don't have to be limited to one or the other. It is essential to verify understanding of the material that you are providing, and to do the summary with the client, summarize the meeting, and conclude with what the client needs to expect next, or what it is that the client needs to do. Okay, it is important to keep the sessions brief, and once again to focus on one really important point. Relate the new information to past experience. Use stories or personal examples. It's helpful to give them some clues as to how they might achieve what it is that you're asking them to do. If you want them to take a particular medication at a certain time, you may provide them or suggest to them that they count out all of their pills for a week and give them a plastic pill device to help them do that, and go through and do it with them. If we want them to change what it is that we're eating, we can give them several alternative suggestions that will improve their ability to incorporate the new food or to eliminate a food from their diet. You want to present information one step at a time. It is really important not to overwhelm them, because it's been my observation, and I think it's probably documented in places, that when you tell them too much, it becomes overwhelming, and they will just leave everything that you've told them when they leave you. With oral communications, it is important to create a supportive environment. We know that we're going to sit down and we're going to talk on a level with the patient. We're going to try and engage them in conversation. We're going to demonstrate interest in them as a person, and what we want to do is have an attitude of helpfulness. We want to create a quiet place so that there is no extraneous noise or sounds that will distract them from what it is that they're hearing from you. You want to have straight back chairs. It's easier to sit down and get up from those chairs, and it also has a levelizing effect if they're on the same eye level that you are. We hope that the environment has large and easy to follow signs. None of you have been to Little Rock, but this is the most confusing building for somebody trying to find something. It's not a square building by any stretch of the imagination, and until colored arrows were put down on the floor, you'd find patients wandering all over the place, not having a clue where they were. So having large and easy to follow signs really helps them to get where they're going, and assist with scheduling follow-up. So do not let them leave unless they have an appointment to return to you. We want to use engaging methods. If you have, as we all do, computers in your office, there are little film clips that you might be able to show them that illustrate a point. We want to give them take-home materials with telephone numbers and written in large letters clearly so that they know who to call if they have any questions. And we want to make sure that we get reflective feedback before the end of the teaching episode to make sure that they've heard at least the key points of what it is that we have told them. Okay, what questions do you have? Anybody have any questions? See, I asked it the right way first. So, do you have any questions?
This is Sonia Deloach. I'm one of the, I'm at the Tennessee Valley Healthcare Systems in Nashville, Tennessee.
Oh, hi, Sonia.
Hi, and I thought a lot of the things that you said would be so effective for a lot of also maybe given to the social workers within the departments. A lot of the things that they're working on would really help as far as educating on ways to engage or invite the vets in to feel more comfortable, more relaxed. And I think that's a good point as far as the signs, the arrows on the floor, because so many of our residents now with that age deficiency within their spine or in their wheelchairs, they're looking down when they're walking so versus looking up or trying to read the braille or the signs that's around the walls, because in Murfreesboro it is kind of encompassing and trying to go from the hallway around to one place to another.
I understand, because I have rescued many a lost veteran in my years here where they are just standing there and looking totally bewildered. And it's extremely helpful to be able to point out to them the colored arrows on the floor and give them something that they can relate to. Follow the green arrow to get to where the pharmacy is so that you can get your medications. And that has been extremely efficient in here. Now we are getting new elevators, and the elevators, despite the fact that I hate inanimate objects that talk to me, it's very, very helpful for people because not only is there the light on the top that tells you what floor you are, but when you get on or off the elevator, it tells you that it's going up. This is the 5th floor going up. And people seem to be a little bit less lost.
Yeah.
I don't think we're ever gonna totally eliminate that, but it seems to be working, and it seems to be a lot more user friendly, if you will. My experience really has been in nutrition, and which is why some of that has sort of bubbled up, because there's a much larger version of this that specifically has to do with nutrition and what do we do. 3rd grade reading level does not go beyond 2-syllable words. And we talk to them about vegetables, which is longer than that, or surgery, which is 3 syllables. And you have to be sort of creative in your choice of words to make sure that people understand what it is that you're talking about. And it's a challenge for us as health professionals to be able to explain very complex issues, very complex ideas in a very down to 3rd grade reading level. We've done occasionally some patient information brochures and what have you, and it's the most difficult thing I think I've ever had to do is to write things so that people with the 3rd grade reading level can really understand it. What is helpful, I think pretty much all of us have Microsoft. There is an option in there where it will give you the reading level and tell you that it's 12th grade, 9th grade, 6th grade, 4th grade, whatever, depending on the number of words in a sentence and depending on the number of syllables per word, which is a very, very helpful tool if you are doing materials development for people who are, have a really basic literacy level.
Oh, okay. Thank you.
You're welcome. What other questions do you have?
Hello.
Yeah, I'm not, this is for anybody.
Yeah, this is Dr. Akif from Birmingham, VA.
Hi.
Hi, Dr. Akif.
Hey. I just got last 15-20 minutes of your talk. But I'm doing a quality improvement project as part of my geriatric scholar training, and I had a few questions or your opinion about the project. Can I contact you?
Oh, sure, yes.
Because I don't think that this is relevant for the audience.
Yes, I am in the global directory.
Okay.
Okay, it's ronnie.chernoff@va.gov.
Dr. Keith, this is Sonia. I will
Yes.
send you her information so you can contact her with any additional questions that might help you with your Jerry Scholars project. And I have the link and the slides, the handout.
Yeah, I do have the slides.
Okay, good,
Yeah.
good. Okay, and I will make sure you give her information so you will be able to contact her.
Oh, okay, then, thank you.
That's
Good to
great.
have you
I'll look
on.
forward to hearing from you.
Yeah, thanks.
Okay. What other questions do you have? Anybody?
I was trying, Ronnie, it's Judy. I was trying to figure out where the feature is, that rate, the grade level of what's right.
It's under the spell check option. You have to turn it on. Give me just a second. I'll get it. I pulled out.
That's not my voice. That's Todd.
That's Todd. Sorry.
I didn't suddenly
Didn't get very much detail. She got a very quick cold.
I used to use it, but now I can't seem to bring it up. But it is there.
Under, I don't know which version of Office you're in, but it's under the spell check option, and I'm trying to remember. You may actually have to go in and tell it as an option to turn that on, because I think they've turned it off.
It sounds like it's called the Fleisch Kincaid.
Yes, and we had somebody at one of our health literacy pieces who talked about it. There's some other web ones that are out there that you can you can copy and paste into, but her indication was the one in Word is actually pretty good, considering the access that you have to it. Let me see if I can.
Yeah, because I did a patient education manual for palliative care a few years ago, and I checked it, the entire 80-page document, with this Word feature to keep it at 6th grade level.
That's right. It's a very handy thing to have. I mean, it really, really is. Todd is looking for it right now.
I'm trying to remember. I think you have to turn it on in the 2007 and 2010 versions of Word. I think you have to turn that option on. In the 2003 version, there was a piece when you did a spell check for the entire document.
Yeah.
It would automatically, you could tell it to give me all of those things, and it would go through all of those pieces for you.
It doesn't do that anymore. I can see that.
It's still there, but I think you have to turn the option on.
Okay.
And it's a very awkward item, I believe, and I'm just trying to remember where it's at underneath here.
Okay, yeah, because that's several years ago, and I have a new version of Word. But anyway, it is very helpful.
Yeah, I wish more people would use it.
I use it all the time. I have it turned on one of my computers, but I don't have it on this one.
Judy, how about if we send you the...
Well, I'll ask my tech guy. I was just trying to guide the scholars who might be interested.
Yeah, because that would be something really good. This is Sonia again, and I'm looking on my Word 2007, and I'm trying to find it.
I think
Lauren, how about if we end before he finds it, can we send that to you and you can put it on the SharePoint?
That's fine. I think now would be an appropriate time for me to mention, too, that to all the scholars who are on the call that we are going to be archiving the whole series of this professional development series. So I will be sending you all that information, and I can also include how to put this feature on your computer.
We found it.
I found it. For those who are on Word 2007,
I am.
You have to go in through the little circle up on the top, which gets you the kind of all the commands.
Yeah.
Okay. Get down to the Word options. Okay. There's an exit Word and Word options. You click on Word options, and then I got to remember where I get. It's under proofing.
Yeah, I see that.
Hey, down the third little area, when correcting in spelling, grammar, and Word, there's a show readability statistics checkbox.
Yeah.
Turn that on, and I believe now when you check spelling, it should give you the stuff for it.
that's it.
Yay, Todd.
I was trying to see if I could find something. I don't have any Word documents open right now, so I was trying to remember.
Actually, what he has is he has a blank document, and it keeps doing a spell check and telling us that everything's
complete, which I would hope so, considering it's blank. Okay, that's
Okay.
right. Okay, we're all right. I could do this one. It's not too bad.
Review. Okay.
There you go. Yeah, and then it gives you that's the one that they've had for a long time, which gives you the Flesch-Kincaid level. Clearly I did very well in this because I did a 0.7 grade level. So.
Good for you.
So, but it gives you all those statistics, and they've got it kind of buried, and it's unfortunate that they've kind of turned it off by default. I understand that a lot of people don't care, but for the
Well, we do.
for us in education and people who have to deal with what you're wanting to do, and this is a great feature to sort of go through and check everything anyway.
It's really good. And sometimes you want a very high level. I mean, you don't want to write a letter of recommendation for a, fellow and have it at a 5th grade level.
I've done that. I've wanted to tweak it higher. I want it above around 7th and higher. I'm usually okay. I usually end up higher than that, but I can. There's some, and I know I've done it for my wife's papers when she's dealing with some things. Is to sort of look over it.
Wife just became a nurse.
Yes.
Okay. What other questions do you have before Laura pulls the plug on us?
We're having too much fun.
We are, aren't we?
At least I know that you'll come away from this with something usable.
This is Todd. I'm just going to provide, as an anecdote, when she mentioned providing diagrams, I know for me, when one of my daughters had to have some surgery, and when we went in, the physician did such a great job of using all these techniques. This was for pediatrics, but really this rolls over to across the board. Sat down, eye level, got out a blank piece of paper and sort of drew us, this is what it's supposed to look like, and this is where the problem is. And it was such a simple little line drawing, took about, 45 seconds for the physician to do this. We felt so much more confident in what's going on, and we understood what was going to be happening in this, with that small little window. I mean, it was still within the time frames of a short meeting with the physician, but we felt much more confident in understanding what was going on. And I've seen some videos where they also provide, when you use anecdotes, if you're talking about something in your elbow or your knee or something, talking about it within the context of something that they may have done with some manual labor items. It's a hinge for a door. Well, if it creaks and does these kind of things, some descriptions along those lines so that they can contextualize it within something that they're more familiar with. And so I've seen some of those things, and I know I've seen some of those we've had used on my wife and myself, and I know I felt much better about the meeting that we had. So, sorry, I just wanted to throw that in there. When she was talking about that, it reminded me of that episode that we had, that we had those things provided for us, and it really helped a lot.
Well, part of it is, and we sort of talked about this last month, is adult learning, and that adults learn differently than do students, in grade school or even high school. And being able to explain something orally and demonstrate it visually reinforces the message, and it enables the person listening to be able to integrate what it is that they're hearing and they're seeing, and then to give them a takeaway, even if it's just one sheet in large print that summarizes what it is that you've told them. It goes back to the old axiom, first you tell them what you're going to tell them, then you tell them, and then you tell them what you've told them. And it really does work as an effective communication tool. And with people who have lower literacy, every skill that you have in this needs to come into play to make sure that they are getting the message that you are attempting to transmit. So there are lots of ways that we can do this, but we need to be sensitive to the level of health literacy of our patients and clients, and even to a certain extent to our students and trainees who may be encountering information that's totally new to them. Okay, I think
We're at 1:55, 5 minutes.
Yeah, we've got 5 minutes. We can take another question.
I'm wondering, Ronnie, if there's some information from our GEC health literacy trainings beyond this that might be appropriate to be posted on the SharePoint. I mean, we do it.
Yeah, Judy, we actually did a live video teleconference several months ago that we're in the process of editing, but will be about an hour-and-a-half DVD. That is.
Post it as a web video if we need to.
We can post. Todd says we can post it as a video if we need to. That was done for us by actually one of our partners who teaches a summer course in health literacy, and the other individual who was part of that is at the health department. She is one of our, believe it or not, a past geriatric fellow who is at the health department now, and this is a passion of hers. So it was a really excellent program. We just need to edit out, some of the extraneous background noises and flubs, if you will. And we will be happy to let you know. We can put it on Pogo E, actually, Lauren.
Yeah, Faye, are you still on?
Yeah, or Faye?
Faye, could that be a Pogo E? Faye is...
Yes, I believe so. We could post it as a product.
Yeah, because Faye, is involved with that in her other hat. Also, Faye, could you speak to Jenny and see if there's anything from our 3-day course, our faculty development course, any handouts maybe that would be appropriate that Lauren might want to, review and see if they're appropriate for the SharePoint?
Sure, I'll touch base with her tomorrow.
Okay.
That would be great. Thank you very much.
I'm almost halfway done with it.
Okay.
Okay. So we could even have a little health literacy folder, yeah. Such an important area.
It is.
Well, it is, and I think a lot of people take it for granted or don't realize how truly important it is.
And I think the part that's hard is, as professionals, we've become accustomed to speaking at a level that is much higher than what our general public is, and I think it's going to be a trained item that we're going to have to be very aware of.
Well, we do it. We talk VAEs.
Yes.
To people too, and nobody has a clue.
But all of our acronyms.
Exactly.
Yes. I tell people about some of the acronyms, and they just roll their eyes at me, and I said, I don't make this stuff up.
Well, thank you, Ronnie.
Well, you're welcome, Judy.
Yes.
Thank you all for being on today. I appreciate the questions and the interest, and we will look forward to, really and truly, please feel free to contact me if you have any questions that you think of tomorrow.
Yes.
Okay.
Yes, and on behalf of all the geriatric scholars, Ronnie, I'd just like to thank you for this hour.
Oh, yeah.
And I wanted to also take the time to remind all the scholars that were on the call to make sure to contact their Vision Satellite coordinator using the instructions I sent in previous emails so that they can get the Scantron and get credit for being on this important seminar. So, Ronnie, thank you very much. Thank you all for attending, and I hope everyone has a good afternoon.
Thank you very much, Lauren.
Thank you.
To the next webinar series. Thank you all.
Bye, Lauren.
Thank you all.
Bye-bye.
Bye-bye.